Well, welcome everyone to today's Wyoming Telehealth Network webinar. I'm glad that you could all join us. My name is Corey Jenkins. I'm the facilitator for this webinar today. I just want to make sure that we know who's all joining us today, because we want to make sure that you get credit for joining. So if you don't mind, if you could rename your screen, that would really help us. And so the way you do that is, if you just move your mouse over your screen, you'll see a little sub-menu that comes up at the bottom. And at the bottom, there will be a little icon for participants. If you click on that icon, a window will open, and your name will be at the top of that window. If you again put the mouse over your name, you will see a little button there that says rename. And so click on that, and then just, if you could just rename your screen, your full name, and yeah, I think that would be wonderful. If you want to put the organization that you work for, you're welcome to do that as well. So we just want to make sure that we know who everybody is. I noticed that we have a couple people who have called in. I just want to make sure we know who those people are. So there is someone at, it's a Wyoming area code, looks like 328, help me Kyle, is it 8709? Well, I can look at my thing.
2709. 307-328-2709.
There we go, 270. Who's on that line?
That would be Mary Golden from Carbon County Public Health.
Great, nice to have you, Mary. And then there's another person whose screen name, or it's actually, I guess, you're listed as a call-in user 1 on the telephone. Who else is on the phone line? Go ahead. We can't. I can see that you're maybe trying to say something, but we're not hearing you. Can you try that one more time?
It's Christina Brinkerhoff. I don't know, because I'm also on the phone and watching on the computer.
Okay. Yep, we got you, Christina. Okay, just wanted to make sure. Okay, again, welcome everyone to April's webinar for the Wyoming Telehealth Network. Today we're going to be talking about chronic disease management. We're actually going to be talking about 2 of the 4, there's CDC, I guess, chronic disease, part of the 4 designated CDC chronic disease self-management program conditions. We're going to be talking about pulmonary disease or lung disease, and Dr. Friedman's going to talk about that. And then we're going to talk about diabetes. And we have Diane True and Cody Thompson are here to talk about that. So we're going to go ahead and turn the time over to Dr. Friedman right now. If you have questions for Dr. Friedman, we'll have a question and answer session right after his presentation. You can also type them into the chat feature again at the bottom. There's a little feature that says chat. You can grab them there, and we'll get to those as soon as he's done. So Dr. Friedman, go ahead. Thank you.
Thank you very much. I assume everybody can hear me okay. I'm Andrew Friedman, and introducing myself, my involvement with Wyoming is I'm the medical director of the Sleep Disorder Center at Evanston Regional Hospital in southwest Wyoming. And what we're discussing today is the role of telemedicine in chronic respiratory illness. And the first question is, why telemedicine? It's not just that the technology is fun. There's a reason why telemedicine is an important tool now to reach out to patients. And what I did is I started out by saying, what are the circumstances where telemedicine would make sense? And the most obvious thing is if the patient is too dyspneic to come to the office. I've been in practice for 32 years in a regular office, and you see the way the patients come in. Some are so short of breath they cannot even make it across the parking lot. Also, some patients, mostly older, but even some younger patients, due to whatever chronic illness, are too unsteady to even come into the office. You even worry about them falling in the parking lot, particularly in the winter when it snows. Then there's an interesting aspect I thought of recently with some of my exposure to the changes in medicine in America. People are too busy to travel to the office. Instances of distance or time, which I find interesting. In New Jersey, distance is considered 2 miles out of the way. In Wyoming, I know that 2 miles is like around the corner. Also, the modern American society now has a mentality of Amazon Prime, Walmart and Walgreens and McDonald's, a concept of instant care, one-stop shopping, using the internet to do whatever you need. Moving back to the medical things, there's increased frequency of patient interaction and what you might call expedited monitoring. If the technology makes it easy for you to just quickly get on the computer or the phone and interact with the patient, there's no longer this business of having to wait till the next appointment until they come in, which gets back to the first things we discussed. There's hypoxia. In the world of respiratory medicine, patients are hypoxic. One of the things I learned since I've been working with Wyoming is that Wyoming, because of the altitude, is a land of hypoxia. So if you have patients with underlying respiratory illness, you take people who are already a little bit low and it gets much worse. And as a result, that leads to the other things that makes it difficult to transport a patient to the office. Equipment. In respiratory medicine, patients don't just come in and get pills. They come in with equipment. They have oxygen, there are CPAP machines, there's wheelchairs, there's walkers and rollators. We have patients with portable ventilators. So as a result, it becomes a very cumbersome thing to come to the office. Again, asking the question, why telemedicine? Let's look at the prevalence of respiratory illness. Now, knowing the audience I'm talking to today, most of the people are probably the people who accumulate the data for the state of Wyoming. So I'm not going to try to, you might say, bring out a point other than there are a lot of people out there with respiratory illness. COPD being the most common thing we're going to be dealing with, 6.3% of Americans have COPD. That's 15 million people. If you take the state of Wyoming with the population of, I think, 500,000 or 600,000, that's quite a lot of people in the thousands. And when you look at the age greater than or equal to 65, you're talking about 11.6% of the population. And then of these people, I list the numbers of where the dyspnea impairs quality of life, they're taking medications, visits to the doctor for the physician in the previous 12 months, and patients who have actually been in the hospital. Other conditions, we look at hypoxia. I was looking at some data on Medicare and how many patients were enrolled in Medicare and receiving oxygen. We all know the incredible cost of home oxygen therapy. So we're talking about thousands of patients on home oxygen therapy, a very expensive technology that needs to be monitored. Patients with pulmonary fibrosis, and I mentioned they're using broad case finding criteria. Pulmonary fibrosis is a rather difficult condition to define because there's idiopathic pulmonary fibrosis, but there are many patients with all grades of fibrotic lung disease, all sorts of interstitial lung disease, sarcoid, patients with the rheumatologic conditions such as Wegener's or rheumatoid arthritis. And you can, depending how you define them, you can have a very small number per 100,000 or a very large number per 100,000. But these are patients with disability, hypoxia, and significant dyspnea. Chronic respiratory failure will involve patients on ventilators, and that also is a broad category. At the very bottom, I mentioned sleep apnea. I really chose not to get into sleep apnea today because, frankly, that's a subject all on its own, which I think has to be developed separately. And as I say there, it's a subject of its own webinar. And at Evanston, we're in the process of setting up our own virtual pulmonary sleep clinic, because patients with sleep apnea need to be, well, let's just take a step back. When you manage sleep apnea, it's not just a matter of doing a sleep study and ordering a CPAP. And I see Chris is out there today. She knows our patients are very complicated, and it's not just a matter of ordering a CPAP. Sometimes you need to get a better idea of what's going on with them. They need to be monitored. And like I said, that's a subject of its own webinar. So again, going back over the list of diseases we're going to follow: COPD, interstitial lung disease, neuromuscular respiratory failure, thoracic restrictive diseases. Kyphoscoliosis is a lung disease. The lung is trapped in a cage, and there are many patients with kyphoscoliosis-related disease that become hypoxic and have chronic dyspnea. Pulmonary hypertension, multiple classes of pulmonary hypertension based on the WHO classification, whether it's related to chronic thromboembolic disease, interstitial disease, sleep apnea, chronic hypoxia, COPD. Lung cancer. Lung cancer is a population of patients that, though they have to be seen for their therapies, need to be monitored in the outside world in terms of dealing with problems when they develop infection. They may be on oxygen. And then I mentioned already sleep apnea, and finally I bring up asthma. Asthma, one would think, well, let's say it's younger people, they can easily go to the doctor. The truth is, asthma management is quite dependent on having interaction with the physician when you need it. If the patient is having an acute asthma attack, they can't necessarily wait a few days for an appointment. They need to be addressed at the time that they're having a problem. I'm going to spend most of the rest of the time talking about what do you really need. And the reason I bring this up is the fact that I've been trying to look around the state of Wyoming, as well as some other places where I'm licensed, to try to develop the concept of the virtual pulmonary sleep clinic. And I'm amazed at how many people look at me as if I have 3 heads. Or when dealing with some administrative people, they act like it's very complicated. And I'm not coming down to them, because I understand in today's times, anytime a hospital administrator embarks on a project, they have to worry about the cost of what it's going to cost them. Is the cost going to get covered? They have to worry about how many government regulations are suddenly going to come out of the woodwork and haunt them. So it has to be done with some degree of forethought. But let's just take it to its components and realize that it actually is a simple process. Number one, the originating site. There are certain key terms in telemedicine we need to know about. Originating site is where the patient is. And the originating site, the first one we're going to discuss, is the clinic or the medical setting or the office. And we're talking mostly today about the outpatient management. You certainly need a computer or a smartphone. Need a camera, and we were even discussing before we were getting set up here today about how to get your USB camera on your computer to work. You need headphone speakers, and any camera, I use example Logitech camera. As people I work with at offsite knows, I've sometimes managed the ICU with an iPad. And there are some new devices like the Kubi, which I suppose we can discuss later, which turns an iPad into like a mobile type of robot. I'm sorry, let me go back one slide. You need some type of stethoscope, though it's amazing how often you can make a judgment about the patient without a stethoscope. There is the USB stethoscope or Bluetooth stethoscope. There's a device known as the Echo, which fits in line in the tubing on any standard stethoscope, which will interface with your iPhone or your iPad. And I know the standard Littman remote stethoscopes. And that gets to an issue about stethoscopes. I know we need to listen to the lungs, but it's amazing. When I have to examine a patient, it's amazing how much you actually already know what's wrong with the patient just by sitting and talking to them, looking this way at them. Because one of the most important tools for evaluating a patient's respiratory function is the ability to speak. A person who can speak in a long, sustained sentence with a strong voice has pretty good lung function. If they have to speak in very short phrases and take breaths in between and use accessory muscles, you know you have a problem. So it's amazing how much you get just by looking at the patient and watching their pattern of breathing. There's the issue about whether they're sitting back in the chair or they're leaning forward using their arms as accessory muscles to breathe. So it's amazing how much the camera has already told you what's wrong with the patient. Or if they're even resorting automatically to the pursed lip breathing where they're going like that. So just looking and talking to a patient will tell you a lot. The stethoscope, and I'm not minimizing it, but the stethoscope is kind of icing on the cake. There's the otoscope. You want to look in the ears. You want to look in the throat. One of the common devices that interfaces either by USB or the USB interface is the Firefly otoscope. Welsh Allyn makes that too. And of course, the presenter is the most important person. Though in many patients, you can just interact where they're on one end, you're on the other. Many times you need a presenter. That's the term for the person, the medical assistant, the nurse, or any person who is able to act as the interface between the patient and the physician. The originating site at home. Now, the originating site at home, again, the computer, the smartphone, the camera. You're not necessarily going to have the stethoscope, though I'm waiting and always looking on the iPhone App Store when somebody comes up with a good Bluetooth stethoscope. Although, truth is, I've tried it. You can even, although it's not FDA approved, take the microphone on your iPhone and put it to the chest and you will hear lung sounds. But everybody can go to their local Walgreens or Walmart or whatever drugstore, Smith's or Osco, and buy a home blood pressure kit. And you can buy a pulse oximeter on the same shelf. And everybody now does home glucose monitoring, and our diabetic people will discuss that. You can buy a home thermometer. So you already have all the tools for all your vital signs. I even now in my practice for years, I tell everybody go out to the drugstore, or you can even buy it on eBay and go buy a home pulse oximeter. Peak flow monitoring. People have managed asthma for years. They use peak flow meters. They're cheap, they're inexpensive. You take a deep breath in and go like that, and you generate the number. I didn't go into detail about it, but for a while there was a big thing about 10 years ago about home spirometry programs. What's interesting is that the nature of spirometry, it does take some training to do it correctly. And as a result, data shows it's really not effective and worth the money in terms of monitoring for altering outcomes. So if you really want to do things that are simple, off the shelf, easy to use, cost effective, I have the things listed there. Now, I bring up Subacute because, as I say also, that's also the subject of its own webinar. In discussing recently with some subacute facilities who are looking into the possibility of robots to cover at night, more of a respond model, not a round and respond. Medicare, as everybody knows, will Medicare disincentivizes the readmission of patients back to the hospital. So the goal with a patient in a subacute facility is to prevent the readmission, which means if you have the ability for a doctor to do a bedside evaluation, you can prevent the readmission and save costs in a very large scale in a subacute facility. You need a good medical record, you need your standard robot type devices for monitoring the patient. But most important, you need to train a subacute staff, which is often not used to it, and have policies for care of an acute evaluation. I think that's something we can discuss at a later time. What do you really need now at the distance site? What is the distance site? The distance site is where I am right now, sitting at a desk in front of a panel of computers with my headphones on. You need a physician or a nurse practitioner or physician's assistant, and we'll jump right to this thing that the physician and the paraprofessionals must be licensed in the state of the originating site. I am here in New Jersey, even though everybody there is in either, I think, California or Wyoming, okay? So you have some doctor in central New Jersey managing patients in Wyoming. I'm a licensed physician in Wyoming. You need like I said, physician, nurse practitioner, physician assistant, nurse educator, excuse me. What you really need, and though that doesn't have to be necessarily at the distance site, is a good call center, and I'm going to go into this again, to coordinate, bring the patient together with the doctor and the team at the right time. One of the big problems of video medicine is the fact that everybody has to be there at the right time. It's no different than an appointment in an office. You agree to be there at a time. There might be a little wait on one side or the other. You either wait for the patient waits for you, but you can't, you have to coordinate that. And there are many programs that invest, like Teladoc and American Well, invest tremendous money in their call centers just to make certain everybody gets together at the right time and there's not a lot of downtime with waiting. And also the program that you're using, like today we're using Zoom, which is considered a standard, but there's GoToMeeting, I think the GoToMeeting business version, there's video that even allow multiple people to meet with the patient in a virtual room. So for instance, I'm here in New Jersey, the patient's over there in Wyoming, and you can have a respiratory therapist in another office in Wyoming or in California, and we're meeting in one virtual room doing what we have to do. That gets to the next thing, care coordination. And this is something I've learned from running an office for all these years. The interaction that's taking place between you and the patient on the video is one small part of the whole thing. There's tremendous preparation that has to take place before and after the actual telemedicine interaction. As I said, you need a good call center or your nurse coordinator to make certain everybody gets together at the right time. Before you interact with the patient, there is an electronic medical record on the computer over here on this side. And you have to make certain that everything is on the medical record before you come in. When I see a patient, I want to see their latest x-rays and their CAT scans. If an ultrasound was done for a venous Doppler, and we know there are services that will do visiting ultrasound, since ultrasound is quite portable today. Venous Dopplers, bedside echoes. You want all those results on the computer. One thing I've learned, arranging home oxygen, home nebulizer, home CPAP is a tremendous amount of time on the phone. You need to provide appropriate verification. You need to make certain that you have the right oximetry data, the right diagnosis codes. You need a staff that is really on top of it and knows how to get the right data in the computer. Arranging home ventilation, it takes me about a week of going back and forth to make certain that the home ventilation is put together. You have to have an incredibly good relationship with your durable medical equipment suppliers, the people who supply the oxygen, the CPAP machines, the home ventilators. You also, since they have to go out and do service calls on the equipment, you want to coordinate perhaps your visit remotely with them so you can accomplish a lot of things at the same time. You also have to submit the prescriptions electronically and arrange visiting nurse, home physical therapy. And of course, the final thing, who's going to pay for all this? Presently with Medicare, the originating site has to be a clinical setting. Although there is research showing that there are tremendous cost savings if the patient could be at home, and the Next Generation Initiative is going to try to address removing the restriction of the office or clinic for the originating site where the patient is. And while I'm on the subject, I mean, I'll bring that up. I had a patient recently talk to me about house calls here in my office. And I said, well, I can't do a house call, but I can do a virtual visit. I don't know if we'll get paid for it because in New Jersey, where it's so densely populated, I don't think we qualify, whereas in Wyoming, I think there's more qualification. But that's something we can discuss, or people who are more knowledgeable can tell me about that. But the thing is, what you have done is you have regenerated the house call. The house call of the 1950s is back, except it's being done as a telemedicine visit using all the tools we just discussed. And we're basically taking the house calls of the 1950s to then now the house calls of the 2017 era. Medicaid, I mentioned there that there is some type of telemedicine coverage, though it's variable. And 25 states will recognize the home as an originating site. And with the private carriers, you can see that there are estimates that there's tremendous cost savings. I mean, programs like Teladoc and American Well are sold by the fact that they are just saving them a lot of money. An ER visit can go over $1,000. An urgent care visit, let's say, a few hundred. One of their visits is at most maybe 100, less than 100. So there's tremendous cost savings to the insurance companies and tremendous cost savings in terms of downtime. So you'll see that the trend is going to be towards moving into the home environment as the originating site. And with that said, I know if there's a lot of things I left unanswered, but I'm open to any questions or discussions. If anybody wants to contact me, there's multiple ways to contact if you want to discuss it. I could spend hours talking telemedicine. So I'm in New Jersey, but our home company is in California. And like I said, I'm part of Evanston Regional Hospital down in Southwest Wyoming. Any questions?
This is Diane in Cody, Wyoming, and I have to applaud what you're doing from New Jersey. I'm in Wyoming, and the company I just retired from was actually a part of the Eastern Montana Telemedicine Network, and we actually had 23 physicians that used the service for our patients, including the Burn Center folks from Utah, which I know you're familiar with. And I was actually their site facilitator. When you say coordination of services is critical, that's probably the most important part of having it be a successful adventure for patients. And so I applaud the fact that you've reached out to Wyoming, because I did 30 or 40 visits a month by telemedicine very successfully and very rewardingly, even cardiology and nephrology clinics and pulmonary clinics with all those right Polycom kinds of things. It works amazingly well.
Yeah, it's all I can say is it's the way of the future. I've been in regular practice for 32 years, and I just see this is the way it's going to be, and just the way to do it.
Yeah, right. I think people have been hesitant to join, don't you think, Dr. Friedman? But I agree with you. I think telehealth it's got to expand. I mean, we have to get with the technology that exists today, and I guess get with the 21st century, really.
I agree.
Other questions for Dr. Friedman? So Dr. Friedman, you mentioned a lot of like peripheral devices that you could get at your local drugstore or whatever. Do you find that those are accurate enough or sensitive enough for the work that you need as a physician to properly monitor a pulmonary patient for telehealth?
Absolutely. The truth is, everything I'm doing here is nothing more than an extension of what I've been doing with my office patients for years and years and years. For instance, patient comes in the office and you get a high blood pressure. Well, you don't treat one high blood pressure reading in the office. What you do is you say, before we start you on medicine and go nuts with medicine, go home, get yourself your standard. And again, I'm not endorsing any particular products. I don't have stock in any of these companies. But you get your standard Omron monitor and give me 2 weeks of blood pressure monitoring, just do it, let's say twice a day, 3 or 4 days a week, and come back and let's look at some numbers and decide. And what you find is that blood pressure, you don't treat isolated numbers, you treat trends. And you find they're really not that bad, and then you get your lab work, and then you talk about doing that. Same thing with pulse oximetry. Patients say, I use the oxygen when I think I need it. Well, I said, how do you know you need it? I said, oxygen is a numbers thing. I said, it's a lot like diabetes. Do you take your insulin when I think my sugar is high? No, you have to look at a number. And what you do is the home oximeters are very, very good. You buy them off the shelf at like I said, I have one I keep in my pocket all the time. I bought it at Walgreens. And I compare it with the expensive ones in the hospital. I remember when my first oximeter, which I bought for the office back in the 1980s, it was such a big deal. I spent $3,000 for it. okay? You now buy it at Walgreens for about, I think, $50 or $55. And they're good, and they're very accurate. And you say, walk around, read your oxygen. It goes down, fine, put the oxygen on. Really, that's the devices are very good. When the people talk about blood sugars, I still remember when I was in my training that we were taught to cover with insulin based on glucosuria, and it was a revolutionary thing in around 1980 or 81 to do a finger stick. And I still remember mentioning that to one of my attendings, because I did a rotation at Joslin Clinic where they were doing it, and not too many other people were doing it at the time. And one of my attendings at the hospital where I was training said, "It's not going to catch on. We're still going to use urine." The point is, the devices, as technology gets better, the devices are better. They're accurate. They're good. And when patient gets on the phone, you talk with them, or if you do a video visit, they have something intelligent to tell you because you have some numbers. And I think they're perfectly fine.
Okay, great, thank you. What other questions do you guys have for Dr. Friedman? You know, I think it's wonderful to have people like Dr. Friedman who see patients in Wyoming. You know, we had a meeting yesterday and I heard somebody talk about statistics of, you know, there's generally a shortage of providers and certainly specialists in the state of Wyoming. And so to have people from outside the state and as far as New Jersey and you know, on the East Coast be able to see patients in Wyoming, I think that really, it helps with our provider shortage here in the state. I think that most providers in the state actually are licensed to provide services in more than one state. And so I think it's just a wave of the future. Recently there's a compact that was called the Interstate Medical Compact, and it's basically there are several states. Wyoming was one of I think 8 initial states that was approved. That it just helps providers to get licensure, makes it easier for them to get licensure in more than one state. So, yeah, telehealth is going to grow. It's coming whether we want it or not, I think. So, and again, this was just kind of a way to model that today. Anyway, any other questions? I don't see anything in chat. We're going to go ahead then and transition to Diane True and Cody Thompson and talk a little bit about diabetes. If you have other questions for Dr. Friedman, if you want to, again, hold those, we'll have some time at the end. We can come back to those. Or if you just want to type them in the chat, we can address them at the end. But so Diane and Cody work for the state of Wyoming. They provide a lot of diabetes education, and so I'm going to turn the time over to them and let them talk about some of their work with telehealth. So you need to unmute Diane. Diane, we can't hear you. Let Kyle unmute you real quick.
Oh, she wasn't.
Oh, okay. Now I'm unmuted. I'm Diane True. I'm a nurse clinical specialist. I'm a board certified diabetes educator, and I actually finished my fellowship a couple years ago in diabetes because I teach at the universities of schools of nursing and for the state of Wyoming as an independent contractor. We are actually in year 4 of a contract from CDC to provide professional education at the staff level as it relates not only to diabetes but to hypertension. And it was designed originally to help physicians and physicians groups in our rural area to meet all the meaningful use and ACA and primary care goals, and to help them achieve better patient outcomes. We use a lot of clinic assistants and medical assistants and community health workers, especially in tribal health and Indian health services, who had a minimal knowledge of what that A1C or that blood sugar really meant. So I can relate to what Dr. Freeman's saying about what tools do we need to give our patients at home to take better care of themselves. I'm actually going to share a document that we've just recently worked on, and it might take me just a second, but I have it up. We have now a 6-part curriculum that actually received national recognition this year, so we're able to give continuing medical education credits for our providers and our nurses and our dietitians and our pharmacy staff. So we really do take that in-depth look, and it's a pretty nitty-gritty anatomy and physiology look at what is diabetes. It was actually designed for the schools of nursing. We take a look at that role of hypertension and diabetes because we share that cardiac and cardiovascular population, and we actually are able to give them the Million Hearts toolkits if they need tools for their patients. We just completed the new module for medication review based on the ACE guidelines, and it's been an interesting intervention to talk with physicians as the dynamics of medicines have changed and what's not only cost effective, but what's the most efficacious medication for a patient with the fewest side effects, because those guidelines have changed over the last year and a half, and they're going to change in June at ADA and again at AADE in the endocrinology meeting this summer, when there's 3 new clinical trials that will report out. We spend a long time talking about nutrition and diabetes, diabetes and hypertension when we introduce the basics for the DASH diet. And we were asked this last year to develop an advanced nutrition module where there's some hands-on work for our smaller rural sites who may not have a full-time dietitian, or for some of our nursing homes where those dosings of medications are based on what they eat, and a more appropriate goal setting that's realistic for the patient. And then looking forward to the new CMS guidelines that come out in January. What can our certified diabetic centers do? We have 9 of them in Wyoming, soon to be 10. And what do the new prevention, and that's what the NDPP is, it's the National Diabetes Prevention Program. What are the options for Wyoming? Many of us have to go back to school and do an additional certification to be able to provide prevention education and be reimbursed for it. And since that care coordination and navigation or population management piece is coming to prevent that all-cause readmission, Wyoming is very fortunate that I've had the privilege to sit on the national board, so we knew it was coming. We've actually partnered with our Montana diabetes prevention programs. We're able to bring in a master trainer this summer in August, and I will share those tools for the agenda probably when we're done with this. In August, we're going to actually be able to provide training in the state because we received a grant that will allow all of us to go back to school for several days, take the next set of classes that we need to take, and then be positioned as a small rural state to move forward as the new ACA will roll out from the Affordable Care Act. And for us to go to Emory or Vanderbilt would be, several $1,000s. Our diabetes sites and our 3 pilot prevention sites will be able to come to Casper and do it for about $200. So that's a huge thing. We've probably hit, and Cody, you can correct me, 17 to 19 of the 23 counties in Wyoming with education. We've probably done more than 1,000 providers. And we actually are partnering with the primary care physician group and doing some more education via telehealth for them so that everybody's ready and to be positioned. We had an amazing response. I see some of our rural sites that I was the coordinator for one of the diabetes sites until I retired this last year. I see the difference in the patients that were referred. I see a difference when we go back and visit the sites, how that care coordination is now blooming. And the fact that our Mountain Pacific Quality Healthcare folks have helped some of those small sites with the interface to get their data so that they meet those meaningful use guidelines and metrics has been amazing. Cody, what's your view on that?
I agree. I'm the newer of the educators, And so for about just a little over a year and a half to 2 years, I've been helping with particular counties that we are kind of assigned to or helping out. I think that it's been a wealth of knowledge in the facilities and healthcare that I'm doing.
I just had to get rid of it. Sorry, Cody.
And as far as, anywhere from ambulance drivers to senior centers to nursing homes to clinics, public health nursing. To give you kind of a generic example, particular county may have a dietitian visit once a week or once every 2 weeks, and no endocrinologist or certified diabetes educator in the county. And to be able to provide them with a little bit more information to give them confidence. And when they do have the interaction and one-on-one with their patients in the community for diabetes and hypertension and high blood pressure, it gives a means of promoting a little bit more proactive information and down the line to be beneficial for those individuals of Wyoming.
I think the other thing that we've done is we've brought a standard model. The original curriculum was designed for the schools of nursing, so it meets all of the evidence-based best practice tools. And by the way, screening for hypertension and type 2 diabetes is, right there with the new metrics. And so it's been, whether it's public health or school nursing, I'm seeing a change in culture. I'm seeing people asking different kinds of questions. We've been able to give them an amazing toolkit that they can get for free from the reliable sources that are unbranded, which is huge. And across the state, we all are working for the same goals. And we have some amazing diabetes advisory group that represents all those different disciplines, which many of them are on today. And as a result, we're all working in the same direction. And where we all need support, we're able to communicate and have that support. And we're able to, where there's been issues or problems and we need to have done some problem solving, we've actually been able to provide some amazing outcomes. So it's been a very long process. We're actually looking forward to year 5. The modules don't look anything like they did, of course, in the beginning, but that's to the best benefit of everyone that we get to share with. And, but I see a change in practice. Wyoming is poised because we've been able to stay ahead of the curve a little bit and ready for 2018 and what will come out of the new Prevention Act that takes effect. And it's not often that you get to say that you're kind of a jump ahead. Our 2 pilot projects for diabetes prevention are doing amazingly well. And we're going to be able to support that with the educational pieces for those communities and for our 9 DSME sites. So for me, personally, I've been teaching a long time. I too can remember dipping urine and filing and cleaning glass needles because I'm probably even a couple days older than Dr. Friedman. But we have come a long way, and that partnership that we've developed over the state is priceless. So adding telehealth to be able to get to some of our rural sites or the places that need follow-up will be an amazingly efficient way and cost-effective way to continue to provide those additional support and services. Question?
So, yeah, thank you, Diane. So, Diane, I just showed that, I think the flyer you were talking about. Did you want to say anything about that? You kind of.
No, this is what we, this was designed not only for today, but when we go and visit sites and clinics, sometimes people don't know what they don't know and they're not sure where they want to start. And so we can kind of leave this with them and say, let us know what you need. You know, lots of times that those first in person, you have to shake their hand. Wyoming still wants to see you at least the first couple times in person. But then they can go ahead and schedule with us, you know, wherever they want to start. We have some preferences of everybody doing basics first. And certainly you want to do, you know, the nutrition module before you do advanced nutrition. But we're very, very flexible depending on, you know, the specific clinics or the facility's needs. Next year, the Wyoming Association of Diabetes Educators, like I said, is going to partner with primary care to do some more education. So it's been an amazing adventure. Like I said, we've probably done, with even the start of this year, we probably are pushing 1,200 to 1,300 professional folks that we've had the privilege to work with. Like I said, 19 of the 23 counties, and we just keep growing. Yeah. There's been a lot of driving, even in the winter. So I'm looking forward to Zoom, especially for follow-up, where you already have those relationships, which you can't put a price tag on. Right. You have to develop those relationships.
Well, great. Thank you, Diane and Cody. I assume that, I mean, Dr. Friedman did a very good job of talking about how you do remote patient monitoring using a lot of the devices. And I know that you mentioned glucometers, Dr. Friedman. Anything, Dr. Friedman, that you would add as far as remote patient monitoring for diabetic patients?
For diabetic monitoring, what I do, and again, as I said, everything to me is an extension of what I do in the practice. Patients will, on routine examinations, routine screening, will find a high blood sugar. And the important rule I teach all my patients is nobody ever died of a high blood sugar. People die of long-term vascular disease. They die of kidney disease. They have all the long-term complications, myocardial infarction, strokes. But by itself, a high blood sugar is not necessarily a medical emergency. Low blood sugar is a medical emergency. And you'll see where I'm getting to with all this long-winded response. This is how we talk in New Jersey. What can I tell you? Anyway, the thing is that what we tell patients, just like with the blood pressure, an isolated high blood sugar does not necessarily make a diagnosis of diabetes. And what we do is we tell them to go get a home glucometer. And they're easy to come by, and fortunately insurances pay for them. And we say, I want you to do finger stick blood sugars twice a day. Give me at least, before breakfast, before supper, if you can't do every day, at least 4 or 5 days a week. And let's see your panel. I'm dealing right now mostly with adult onset diabetics. We're not necessarily talking about the juveniles, which are a different population. I say, bring in your list of sugars, and then what we'll do is we'll decide what to do. Or I might just start them with some PRN dosing of some Prandin if they're above a certain threshold. Because one of the biggest things I find is patients have a high blood sugar, they'll go to the emergency room, next thing you know, they just got popped with 5 units of IV insulin, they then get hypoglycemic, then they have to be admitted. Or somebody starts them right away on medication. I say, get your glucometer, get some numbers, come back, and then we'll talk about it. And we start gently to bring you down under reasonable control. But again, just like oximetry, it's a numbers-based type of therapy. And you're only as good as the numbers, and the glucometers are all very good as long as you change the batteries and as long as the sticks are not old, because once they get old, they get, I think they report, and the diabetic people can correct me, I think they report too low or too high when they get old and they're outdated. But the thing is that as long as the stuff is new, the batteries are changed, it's very good accuracy, and with a communication form without having to run to come in the office, you can achieve very, very good control. So yes, they should all have the glucometers and check it and report back.
And I agree. And even the new monitors are smart enough. If you put a strip in that's expired, you're going to get an error code and it won't let you use
Okay.
it. So they've gotten way more sophisticated and very much more predictable. And I agree, because when I was still in practice and seeing patients, we have a lot of patients out on the ranch, and I don't want them to come in, for that 400 blood sugar, when the nice lady who was so embarrassed who did come in realized that she had just fed her kids their breakfast and orange juice, had not washed her hand, and started eating, wanted to get that blood sugar because she was on insulin, realized when we checked her meter and I cleaned off her finger and there was that aha moment that she hadn't washed her hands and had orange juice on it, that you just cost her, many, many minutes and gas and miles and time of coming to town when she wouldn't have had to. So yeah, it's a very productive tool. And again, it's trends. I remind even our patients with their insulin pumps, because we see a lot of them out here, and their sensors, that they're only a tool and they're only as good as the person who's using them, and you do have to use them correctly. But we now can see trends, and now with the new software, patients can actually download their meter. They can call us and say, look at it. We can log in through the secured websites, and we can have those conversations and make very good judgment calls. Yes, you do need to come to town, or no, you don't need to come to town. Or we can problem solve for 1 hour, 2 hours, 5 hours, or the next day. Or we can say, yeah, you need to go to the ER. So it has made our lives complicated, because you got to learn all the new things. But I think in many instances, patients have a much higher satisfaction, a much better trust and relationship with their providers. And yeah, we still have to see them, once or twice a year. Get your hands on them, look at their feet, check their pulses, some of those kinds of things. But having done cardiology and nephrology and pulmonary clinics with the physician who values patients' times and values that as a resource and as an additional tool, especially in Wyoming where the winters are bad, especially this last winter, not sending somebody to Billings up over the hills, up over the mountains for what would be a 3 or 4 hour drive in the winter and not safe. We accomplished the same things. And yes, we did it in clinic, where if there was a question, I always had a physician backup who could also come and talk to the doc and say, no, we really need to admit this patient. When there was that collaboration, that coordination of care was immense. And it was actually, having been an old critical care nurse for many, many years before I came to this side of my job, that training and that assessment skill and that relationship that we had with our physicians and our patients, you could even, like the doctor said, you could even tell when the patient wasn't feeling well. You didn't necessarily need as many diagnostic tools. I could hear the patient wheeze. You could see the color or the pallor. And sometimes it was what they didn't say to you because they weren't feeling well. And you had better ability to assess. I mean, I can think of 3 or 4 times when the doctor would very lovely say, as we're moving the stethoscope around, "Oh, you sound a little wet today." And he would be looking at me going, shaking my head in the background going, yeah, the patient really is wet, And so I've done hundreds of patient visits by telehealth. I'm excited that as an educator, we get to do professional or patient education through another media. We're going to introduce this Zoom platform at our diabetes meeting next week. So we're excited to reach another group of healthcare professionals to let them know that they now have some more options in Wyoming. And we have a lot of 1 and 2 person physicians' offices and clinics. I was privileged to sit, except for VA, at the largest freestanding primary care clinic in the state. I had all the tools and toys. But a lot of our facilities will be like Dr. Friedman said. They're going to have them go home if they're get an O2 sat. You're going to have them with, if they need it, their blood glucose, their stethoscope, their the few things that we need to have them have so that we can make those judgments and those assessments. But I find a lot better response from the patients, and they're more willing to call us when they think they need help, and we're able to just give them a better quality intervention. You know, it's a good tool. Yes, it takes some getting used to, but I have never had a patient, in all the patients I've done, that didn't leave their appointment thankful that they could still see their doctor face to face, or us. Yeah. And we did a lot of diabetes education through that pilot project for PRISM, and our patients actually kept their appointments because they could do it from home, or they could do it from a remote site, right, where they might not, if they had to travel the 30 or 50 miles to come for class.
Right.
The outcomes, your data for outcomes, your clinical outcomes, and your retention and your commitment by the patients was far superior.
Great. Thank you, Diane.
Mm-hmm.
So we just have just a minute or two left. Any final questions for either Dr. Friedman or Cody or Diane about remote patient monitoring for pulmonary or diabetes? Or for Diane or Cody, if you have questions about the work that they're doing in diabetes education in the state. So Diane, Cody, if there's somebody that wants to call on you guys to do some diabetes education for them, how would they do that?
They can email us. You can share or send out that flyer that that I sent you that has our contact information. They can call, Hannah Harold at the Department of Health in Cheyenne, at the Diabetes Prevention Program. She has our contact information, and she knows which counties I kind of have the top third of the state, and Cody and Maureen and I share Fremont County, but Cody's got the middle, and Maureen kind of has that southern Evanston, Jackson down to the Utah border end of the state. But we all travel, and I was in Gillette for 3 days, even in January when it was snowing. But we're pretty flexible. Plus, now that we have access to do meetings this way, we can coordinate. If somebody's comfortable and wants to get started this way, we certainly can even just have the meeting piece up front before we provide education.
Okay.
And if they want CMEs, we have a couple little things we have to do. We have a CME registration line that they can register so that they can do their eval, and then we can give them their continuing education credits. But that's an internal process for us. But because we received national accreditation this year, we can do a little bit more for them besides the education.
Great. Any final thoughts, Cody?
Not much to add to what Diana said, but again, if anybody's interested, the information we provide is primarily for healthcare educators or healthcare professionals and community health workers. And definitely we don't have any problems spreading out if there's a need all over the state. If there's any particular counties that need pressing or need information, definitely get a hold of us and we'll see who is available to cover those counties.
Great, thank you. So thank you both, Diane and Cody. And Dr. Friedman, I'll kind of give it back to you. Any final thoughts or comments?
I just appreciate the opportunity to talk about the world of pulmonary critical care and sleep medicine and telehealth. And like I said, I would like to look forward to presenting some information about virtual pulmonary sleep clinic once we get that up and running, as well as addressing the issues about telemedicine and subacute facilities. It's just the way of the future, and I hope to speak more with everybody about these topics.
Yeah, well, great. Well, again, thank you for presenting today, Dr. Friedman.